Good morning, everybody. Welcome to the first lecture of Module 6 on implant classification and failure mechanisms. In this lecture, we will be discussing about classification of implants in total joint replacements with special emphasis on hip replacements. Thereafter, we will discuss implant failure mechanisms. Now, during a joint replacement surgery, say for instance hip replacement, the implant is fixed to the host bone with or without cement. Now, in cemented type, as you can see here from the figure, the use of acrylic bone cement helps the implant to be fixed within the femur. So, this is a figure corresponding to total hip arthroplasty. Whereas, in case of uncemented type, the biological fixation is achieved between the porous coating of the implant surface and the host bone through bone ingrowth. So, in a cementless implant, fixation is achieved by bone ingrowth into the porous coating of the press fitted stem as indicated in the figure. The implants are fixed within bone using acrylic cement in case of cemented implants. The acrylic cement has two components, a powder and a liquid, which are mixed outside the body and injected within a reamed bone or a cavity in the bone. For example, the femoral canal for hip replacements. Now, acrylic cement consists of a polymer, that is polymethyl methacrylate PMMA, and a monomer, the liquid monomethyl methacrylate MMA. Now, in total hip arthroplasty, a hip stem is introduced and held in place within the cement mantle for a few minutes until the acrylic cement polymerizes and becomes solid, thereby fixing the stem to the host bone. This technique was introduced in the 1960s by Sir John Charnley in cemented total hip arthroplasty. Ever since its introduction, remarkable improvement of hip arthroplasty was achieved in the last few decades. Now, let us discuss about the initial fixation of uncemented implants. The initial fixation is achieved by inserting a prosthesis slightly larger than the prepared cavity, generating compression hoop stresses and obtaining the so called press fit. Now, the success of uncemented implant is highly dependent on the biological fixation of implant having surface coating with the host bone. Now, primary fixation or initial stability is crucial because the degree of implant bone micromotion at this stage influences the bone formation at the implant bone interface. Now, let us focus our attention on the figure presented here. We have a proximally coated hip stem and a porous coated acetabular shell. Now, component coating can be full or partial. Now, in this case here, it is a partially coated hip stem. Complete coating presents a larger surface area for fixation, but this may reduce loading of the proximal bone. The proximal coating transfers the load through the femoral metaphysis, but provides a smaller area for stable fixation. The implant is usually provided with a porous coating to enable implant fixation using bone ingrowth in the case of uncemented implants. Now, bone grows, as you can see in the slide, that bone grows into the porous structure and creates a mechanical interlocking, thus helping to secure fixation of the implant within the host bone. Cementless fixation of implant is therefore highly dependent on the biological attachment with bone, and it relies on periprosthetic bone ingrowth into the porous coating. Now, let us discuss more about the uncemented implants. The uncemented implants are surface engineered to encourage bone interlock, either by on-growth or by in-growth. On-growth surfaces are created by grit blasting or plasma spraying hydroxyapatite onto the component to create a textured surface with multiple indentations onto which bone can grow. Ingrowth surfaces are created using sintered beads, fiber mesh or porous metals which create microscopic pores into which bone can grow. The potential for improved bonding, thus stability, through coating prosthesis with bioactive materials such as hydroxyapatite and tricalcium phosphate has attracted increasing interest towards uncemented fixation. In the figure presented here, you can see a knee prosthesis, a femoral component of a knee prosthesis, and also an enlarged view of the porous coating on this knee femoral component. And on the right, you can see a hip prosthesis, the acetabular component and porous coated acetabular component of the hip prosthesis is presented in this slide as well. In total hip arthroplasty, there is a tendency to use uncemented femoral stems in younger patients due to higher reported rates of loosening of cemented stems or cemented hip stems in long-term follow-up studies. Now, I will show you a short video on hip implants, cemented and uncemented, total hip arthroplasty and total knee arthroplasty. Enjoy the video. Let me present to you a hip implant. This is a cemented hip implant or femoral implant which is used for hip replacement. I am rotating the implant so that you can clearly see the femoral hip stem that is used for cemented hip replacement. Please note that this cemented femoral implant has a very polished surface on all sides. It has a very polished surface on all sides. Let me present to you now an uncemented hip stem which has a rough texture and a porous coating on the proximal part of the hip stem as compared to the polished surface that we had for the cemented hip stem shown earlier. Let me turn it around so that you can see the prosthesis fully. The stem has a rough texture, a coated texture that helps biological fixation with bone. Let me present to you a reconstructed femur with a hip implant, as you can see clearly. So now this is the femur head, the artificial femur head, and I will take off in parts, and here you can see the reamed canal within the femur, into which the prosthesis is placed. Now please have a look in the prosthesis. This is a uncemented hip stem with a texture on the surface to facilitate bone ingrowth. It has a porous coating on the surface of the implant that is supposed to facilitate bone ingrowth. Now I will assemble these modular parts and insert it in place within the resected femur. Now I present to you a pelvic bone with the acetabular component implanted within it. You can see in different views the reconstructed pelvic bone with the hemispherical acetabular component implanted within it. So, the femoral component and the acetabular component articulate with each other and thereby the hip joint is reconstructed to offer normal range of motions. Let me present to you a model of the total knee replacement. So, if you are looking from the front, you can see the patella. Now, I will be rotating the replaced knee, and you can clearly see the femoral component, the black one on the top, and the tibial component inserted within the tibia. Now I am moving towards the posterior view, wherein you can clearly see the tibial component and the femoral component. Now in the posterior view, you can clearly see the black femoral component and the tibial component below, inserted within the tibia in the total knee replacement. On the sides, the collateral ligament are holding the bone, as can be seen in the model. Now let us discuss about some advantages of the cemented fixation. Bone cement offers fixation of implant in patients with poor bone quality. That means in patients where bone is very much porous. Therefore, bone cement offers fixation of implant in patients suffering from osteoporosis. The bone cement solidifies within 10 to 15 minutes of application. Hence, almost immediate fixation of the implant is achieved. Now, there are some serious issues threatening the long-term efficacy of the bone cement. The potential problems associated with cemented fixation are: cement is strong in compression but weak in tension. It is the most likely material where crack is initiated. Now, bone cement has a low tensile strength, reported static strength is around 20 to 25 MPa, whereas the fatigue strength for some millions of cycles can come down to 8 to 10 MPa. Now, bone cement is susceptible to failure within itself and also at the implant cement and cement bone interfaces. Moreover, the implant cement and cement bone interfaces are actually the weakest links in the implant bone structure, leading to interface debonding. Cement wear debris abraded from the cement mantle can cause particulate reactions by macrophages, osteolysis and eventual loosening. Now, what is osteolysis? Osteolysis is defined as the progressive destruction. It is the process of progressive destruction of periprosthetic bone tissue. Now, the other potential problem with cement fixation is that bone fractures in implanted femur have been reported to be associated with bone necrosis, possibly resulting from the heat generated by cement polymerization. Therefore, there is a potential threat of thermal injury to the bone layer adjacent to the cement layer due to the process of cement polymerization. Now, what is bone necrosis? Necrosis is death of bone tissue due to lack of blood supply. Now, let us come to the advantages of the uncemented fixation. In recent times, there has been an increased interest among surgeons towards uncemented implants. The cementless implants are believed to offer an improved long-term fixation owing to the biological attachment of the prosthesis with the bone. Uncemented implant eliminates the long and short term problems of bone cement. Let us now discuss about the disadvantages of the uncemented implants. Press-fitted implants require healthy bone. So, the initial fixation of the uncemented implants actually require healthy bone. This type of implant may not be suitable for patients with poor bone quality owing to osteoporosis. It can take up to 3 months for sufficient bone ingrowth and osseointegration. Now, osseointegration means implant integration or fixation with surrounding bone. the uncemented implants are more expensive as compared to cemented type of implants. Let us now discuss about total hip arthroplasty and hip resurfacing arthroplasty. We had discussed briefly earlier in the module 1, but let me now present to you the advantages of hip resurfacing arthroplasty over the conventional total hip arthroplasty. So, as you might know that hip resurfacing is a surgical procedure that involves surface replacement or replacement of the articular surfaces of the joint. So, you can see a typical hip resurfacing implant presented in the slide, and this replaces the surfaces of the femur bone as well as the acetabular bone, whereas the total joint replacement is far more invasive. So, the hip resurfacing arthroplasty has the advantage of minimal bone resection, more precise biomechanical restoration, since it is minimally invasive. So, more physiological stress distribution as compared to the natural bone, and procedure of revision is far more easier as compared to the conventional total hip arthroplasty. So, hip resurfacing arthroplasty is reported to be suitable for young and active patients, preferably below the age of 50 years. However, there are some unique set of complications in the case of hip resurfacing arthroplasty. Now, clinical studies reported femoral neck fracture after surgery as the most common short-term failure mechanism. This is clearly indicated here in the slide. In the long term, extent of stress strain shielding and adverse bone remodeling leading to bone resorption, periprosthetic bone resorption, eventually causing implant loosening have also been reported. Let us now discuss about the second topic, that is the implant failure mechanisms in detail. Now, aseptic biomechanical failure scenarios or mechanisms for total hip arthroplasty was summarized by Heiskus in his publication in 1993. But these failure scenarios are generally useful to analyze failure in other reconstructed joints. Although implant failure is mainly due to biological causes, the initiation of the failure process may be due to mechanical events. Now, there are two dominant failure mechanisms as indicated by Heiskus. The first and foremost is the accumulated damage failure scenario, wherein excessive stresses and strain within the implant bone structure owing to physiological loading are generated. Mechanical damage, typically microcracks, is gradually accumulated within the implant bone structure, eventually causing failure. The other important failure scenario is the particulate reaction failure scenario. Owing to the generation and migration of wear particle debris from articulating surfaces, the material interfaces gradually disintegrates, causing eventual loosening. Other aseptic failure mechanisms can also be identified as follows. Stress shielding and bone remodeling is an eminent failure mechanism. Now, changes in stress strain distribution, that is the mechanical environment of the host bone after implantation, actually leads to adverse bone remodeling and periprosthetic bone loss. So, it is mainly due to the alteration of stress strain distribution or the mechanical environment within the host bone after implantation as compared to the natural situation. Surgical intervention actually disturbs the stable structure of an intact bone or joint, enhancing the risk of dislocation. So, a small bearing size at the articular surface may cause dislocation, which is one of the failure mechanisms. Now, all cemented and uncemented implants are subject to initial migration relative to the bone. However, cementless implants are more prone to migration due to lack of primary fixation. Now, let us discuss about the accumulated damage failure scenario. The accumulated damage failure scenario is based on gradual accumulation of mechanical damage in materials and at the cement, implant or bone interfaces due to excessive stresses, leading to loosening and failure of the implanted joint. The damaging process progresses to implant bone disruption, excessive interface micromotion affecting fixation, and eventual gross loosening. This scenario was emphasized as a mechanism of loosening of cemented total hip replacement by Stauffer in 1982. The strength of the stem cement bond in cemented THR is relatively low. Hence, the failure of this connection in course of time is not unlikely. Once the stem cement interface is debonded, the stresses in the cement can increase dramatically, enhancing the probability of damage accumulation, cement failure, cement bone interface loosening, and eventual gross loosening. Let us now discuss about interface failure. Now, Hoffman's failure criteria is a well-known failure criteria used to determine whether or not a composite will fail due to debonding based on the state of stress and the local strength. Now, the Hoffman's failure criteria is stated here in the slide, and this criteria actually combines the stresses sigma 1, sigma 2 and tau 1, 2 as indicated here in the slide, and the directional strengths tension, compression, shear. So, here we have directional strength in x and y directions, and S is the shear strength. Now, if we put the values in this failure criterion, a value of FL can be calculated. If the FL value equals to or exceeds 1, failure is expected. So, the Hoffman's failure criteria was very useful in evaluating interface debonding in implant bone structures. The multiaxial Hoffman's failure criteria incorporates the local bone or other materials like cement strength. Repeat, the multi-axial Hoffman's failure criteria incorporating the local bone strength or the cement strength has been used to evaluate interface debonding. So, the slightly modified Hoffman's failure criteria that is used generally for evaluating interface debonding is expressed in this slide. Now, this criteria incorporates the interface stresses, the multi-axial interface stresses in form of normal and shear stresses that can be calculated from state of stress at a point. It also incorporates at the same time the local strengths of bone or other material in the implant bone structure. So, if it is a bone interface, then the changing value of the bone strengths due to change in apparent density of bone is already incorporated in this multi-axial Hoffman's failure criteria. Now, the local bone strength as a function of bone apparent density rho is presented here. The relationship between the tensile strength, compressive strength and the shear strength of bone can be calculated from the local apparent density of bone. Now, as stated earlier, the FL value can be calculated based on the normal and shear stress at the interface and the tensile, compressive and shear strength of the interface at any point. Now, if the FL value is less than 1, then the interface is secure and less likely to fail. If the FL is equal to or greater than 1, then the interface is more likely to fail. Let us now discuss the particulate reaction failure scenarios. The particulate reaction scenarios leads to debonding of the implant bone interface for reasons other than load transfer. The particulate reaction scenarios is caused due to accumulated wear particles, eventually leading to the disruption of in the implant bone interface. The process weakens the These wear particles diffuse in the implant bone interface and evoke a macrophage reaction, resulting in inflammatory response of local bone resorption. The process weakens the implant bone interface and might lead to potential implant migration and gross loosening of the component. Possible sources of generation of wear particle debris are wear of acetabular bearing surface, abrasion of cement, implant or bone interfaces, and fretting between metal parts in modular prosthesis. Now, wear is the loss of material from the surface of a material. This process is generally progressive in nature. In comparison, abrasion is one of the actions which can cause wear. It is caused by mechanical process of rubbing the surfaces against some other material. Now, as a result of generation and migration of wear particle debris, the cement implant or bone interfaces gradually disintegrates, causing interfacial micromotion, osteolysis and eventual loosening. According to the destructive wear scenario, the bearing surface of the components gradually wear out to the extent that mechanical integrity can no longer be maintained. However, wear is not limited to the articulating surfaces alone. As the modularity of the prosthesis is increased, more connection between different parts of the implants are required to be established, such as the connection between acetabular metallic shell and the polyethylene liner presently used to improve the fit. The connections are all subject to relative motions, however small it may be, but it can actually cause abrasion and wear. Now, let us discuss about stress shielding and bone remodeling. The implant, being considerably stiffer than the native bone, carries the bulk of the load, which was formerly, that is before surgery, was carried by the bone. So, this actually alters the load transfer pattern across the implanted bone structure. Consequently, a significant portion of bone which was exposed to loads in the intact condition is shielded from carrying the load by the stiff prosthesis in the implanted condition. So, this is well exhibited in the figure presented here in the slide. The implant is actually carrying the bulk of the load indicated by a thick large arrow, whereas the underlying bone below the surface of the implant and near to the surface of the implant on both sides actually carries significantly less amount of bone as compared to the natural situation. This sudden change in stress strain distribution is known as stress strain shielding. Change in mechanical environment, stress strain patterns within the implanted bone structure triggers adverse bone remodeling, that is bone resorption, which is a gradual change, which is a gradual decrease in bone density. Now, long-term bone adaptation phenomenon is known as bone remodeling. Adverse bone remodeling reduces the support to the implant, eventually leading to loosening and failure. Moreover, such prolonged bone resorption also possesses a challenge during the revision surgery. Stress and strain shielding is now explained with the help of two figures in this slide. Actually, an equilibrium condition of stresses and strain due to average daily activities prevail in the case of natural or intact bone. Now, the load transfer is presented here in the slide on the left. So, the load is transmitted or transferred through the trabeculae of the cancellous bone present in the proximal part of the femur, and the load is then transferred to the cortical bone as indicated from the proximal part of the femur towards the diaphysis of the femur. Now, what happens after surgery? After surgery, the implant carries the bulk of the load as indicated in the figure here, which was formerly transferred by the bone itself. This shields the bone from carrying the mechanical load, evoking abrupt changes in mechanical environment, eventually triggering bone resorption and osteolysis. As defined earlier, osteolysis is the process of progressive destruction of periprosthetic bone tissue. Now, stress bypass develops in the bone around the femoral stem when proximal load transfer is bypassed in favor of distal load transfer. So, in this case the proximal load transfer is bypassed in favor of distal load transfer. As a result, the proximal femur is under stressed and becomes subject to strain adaptive bone remodeling and resorption. This scenario is typical of uncoated press fitted stems in particular and can develop due to inadequate proximal fit secondary to proximal interface resorption. As a result, the hip stem jams in the distal canal. Inadequate proximal fit could be either as a result of over-rimming of the bone or undersizing of the cement, or due to gradual subsidence of the stem. Now, many of these cementless hips are likely to subside and jam distally, promoting stress bypass. In stress shielding, the relative stem stiffness is an important design parameter. The emergence of stress bypass is influenced predominantly by the surface contour shape or the design of the hip stem. So, we arrive at conflicting design requirements for hip stem stiffness. The hip stem modulus has important consequences in stress shielding and interface failure mechanisms. A high stem modulus produces excessive stress shielding, but moderate interface stresses, implying bone resorption, implying much more bone loss or resorption, but a reduced likelihood of interface failure. Now, titanium alloy has a Young's modulus of 110 GPa, and it is rather close to cortical bone if we compare it with cobalt chromium molybdenum alloy, which has a modulus of 235 gigapascal. Now, implants made of cobalt chromium molybdenum alloy is expected to result in more stress shielding and adverse bone remodeling as compared to the titanium alloy. Now, if a stem is stiff, it transfers more load distally and less proximally, and it takes larger share of load away from the proximal femur. If it is flexible stem, the opposite occurs. If cement is present on the proximal side, the flexible stem evoke less stress shielding in the bone, but more interface stresses. Thus, excessive bone resorption is more likely to occur around stiffer stem as indicated in the figure here, but proximal interface failure is more likely to occur around flexible stem, but proximal interface failure is more likely to occur around flexible stems, which is indicated in the figure. With increase in stem stiffness, the chances of stress shielding and bone resorption increases as indicated by the curve, but results in a reduced likelihood of interface failure. The relevance of the failure scenarios that we had discussed in this lecture is now summarized in this slide for cemented and uncemented or non-cemented hip implants. So, it is mentioned for hip stem as well as acetabular component or acetabular cup. So, on the left hand side of the table we have the different failure scenarios, and corresponding to cemented stem or acetabular cup, the relevance of these failure scenarios are presented individually. It may be observed that most of the failure scenarios are generic ones, potential failure mechanisms for cemented and uncemented implants. Some prevail in cemented hip replacements and some in uncemented hip replacements. Some are seen more often in the femur and some in the acetabulum, as presented by Professor Rick Heiskus in his publication in 1993. Let me come to the conclusions of this lecture. Implant failure is mainly due to biological causes. However, the initiation of the failure process is due to mechanical events. Uncemented implants are believed to offer an improved long-term fixation owing to the biological attachment of prosthesis with the host bone. Higher the implant stiffness or the rigidity of the implant, greater are the effects of stress shielding and adverse bone remodeling, but lower interface stresses. The references are indicated in 2 slides based on which the lecture has been prepared. Thank you for listening.